My name's Anne DiGiulio. I'm our National Director of Lung Health. I direct our tobacco cessation policy project. Part of that means I work with a team that collects tobacco cessation coverage data on state Medicaid programs and state Medicaid expansion programs. We also provide technical assistance in one-on-one calls, presentations like this. We've got webcasts and we different products that we release throughout the year and whatnot. So that's kind of what and then I also work a little bit on our access to care issues, but that's totally different than what I'm going to talk about today. So that's why I'm here to talk to you, and we did a really cool guide on how to bill for tobacco cessation. And so that's what I'm going to talk about. So we can go to the next slide. And so I'm just going to first go over some background information, then really kind of talk about that coverage to care piece and kind of why the billing guide is important and why, what the differences are between both having coverage and then also getting the care. And then talk a little bit about some state actions and kind of what states can do and what you can do at the state and local level. And then hopefully we'll have some time for questions. So next slide. Start with the background, so you can go to the next slide again. So again, just probably information that you already know, but again, I just like to level set a little bit. We know that almost 500,000 people die every year from a smoking-related illness. There's a high economic cost to smoking, and the smoking rate is still pretty high at 14%, even though it's the lowest it's ever been. The really good, exciting thing is we know that 68% of smokers want to quit. It's right in front of me. And more recently, just last year, the HUD smoke-free rule went into effect. And as you all know, that is a rule for any federally owned housing projects. The primary goal of this is to prevent residents from secondhand smoke. But if you're going to have to go outside to smoke, it's going to be an incentive to potentially want to quit. So as a number of you guys have done and the Lung Association's done, is we really want to be supportive of those individuals who do want to quit. And part of that is making sure they have access to a comprehensive cessation benefit and that providers are willing to provide that benefit. So if we go to the next slide, I'll just kind of, and then the next slide after that, kind of just, again, level setting a little bit about what a comprehensive benefit is. And this is from Treating Tobacco Use and Dependence, the 2008 update, which is the most recent one. So this is not just me saying this. But there are 3 types of counseling: individual or face-to-face counseling, group counseling, and then phone counseling. And then the 7 medications, the 5 NRTs, the gum patch, lozenge, nasal spray, inhaler, bupropion, also known as Zyban, and varenicline, also known as Chantix. The really important thing to note, and this will kind of come up in the next slide in a second, is that all of these are considered first-line treatments, both by FDA and by the Treating Tobacco Use and Dependence 2008 update. So there's not necessarily a reason to have a step in here. So if we go to the next slide, I think when we talk about the comprehensive benefit, it's really important to look at some common barriers to accessing care. And I think a lot of us know these, but as some of them, I think, really kind of reinforce why the billing guide and why understanding how billing works is so important. So first, just cost sharing, and that really doesn't have anything to do with the billing guide, but it's just a barrier to get care and to get treatment. Prior authorization, making sure the provider or physician having to get permission from the insurance company to get one of these medications. Duration limits, yearly or lifetime limits, so you can only have so many medication, you can only have the medication for so long, or you can only have 1 quit attempt per year, or 1 quit attempt every 2 years, or you can only have 3 quit attempts over your lifetime on this insurance. Can all be problematic. Stepped care therapy, again, you can only, you've got to try 1 treatment and fail before you can try another. Again, this I think kind of calls into question why that some of these, they're all first-line treatments, so there shouldn't really be any stepped therapy. There's no clinical indication for that. And then the last one might have a lot of you scratching your head, required counseling. And so especially for Medicaid patients, excuse me, I was talking a little bit about Medicare earlier, having to go get counseling, maybe you've got a limited number of minutes on your phone, so you don't want to use those to access phone counseling. Maybe you've got childcare issues and you can't do a group or an individual session, transportation issues to get to a group or individual session. So a lot of these things can be barriers to care, and while the Lung Association always encourages people to get both counseling and medication, we don't want the need to get counseling to limit somebody's access to treatment in general. So if we go to the next slide, Just kind of want to talk a little bit about some different requirements that different types of insurance are supposed to have and cover, and I say supposed to because, you know, it's what's required, but everybody can do everything a little bit differently. So the Affordable Care Act requires a number of different types of plans to cover all preventive services that are given an A or B grade by the United States Preventive Services Task Force. This includes almost all private plans, any plan sold in the exchange, small group plans, individual plans, and then any Medicaid expansion plan. There are different requirements for Medicare, standard Medicaid plans, grandfather plans, and short-term limited duration plans. And just so we kind of in the framing this again in the public housing context, according to the National Center for Health and Public Housing, about 57% of people, public housing residents, are covered through Medicaid. 21.9% are uninsured. 11.9% have private insurance, and then the rest of the population are either Medicare enrollees or dual eligible. So they both have Medicare and Medicaid, meaning they're either low income. Oh, yeah, that's perfect. Meaning you're either low income and elderly, or very sick and low income. So there's a couple of different ways you can be a dual eligible. Okay, so we can go now to the next page. So the preventive services requirement, and again, most Medicaid expansion plans and most private plans are required to follow this, are required to cover any A and B USPSTF, United States Preventive Services Task Force recommendation with no cost sharing, and that is in the law. So the no cost sharing, there's no wiggle room around that. And so tobacco cessation gets an A grade, so it's required to be covered. States are really responsible for a lot of the implementation, and the A grade includes all 3 forms of counseling and all 7 FDA-approved medications. And if you go to the next page, oh no, that's really it. Okay, so that's it. Sorry, now we're gonna, sorry, I know it was a short presentation, so I didn't go into a lot of detail there. So kind of going to that coverage to care. So we have, this is what's required to be covered. And then we're gonna try to figure out what that USPSTF recommendation means. So there are 3 pieces of a tobacco cessation intervention. So there's the screening piece, there's the medications, and then there's the counseling. So the screening, there's no unique billing code. Tobacco cessation screening is fairly ubiquitous, especially when you look at meaningful use measures and electronic health records. That has really been something that's driven tobacco cessation or tobacco use screening. There are some issues with that around kind of what, when you ask somebody if they're a tobacco user, how broad are you, what are you talking about, kind of what products are you covering? So that could be a potential question. But again, there's no real way some of those meaningful use and other quality metrics to figure out when that is happening. So that's challenge number 1. So medications, we know that the 7 FDA-approved medications are supposed to be covered by most insurance. But we do know that barriers still exist to them. We know that not all plans are covering them the way that USPSTF and the departments have said that they should, so that there's still a big barrier there. And then lastly, and I think this is where there's the most confusion and the most frustration, and I think this is where the billing guide really comes in handy. So you need both an ICD-10 code, which is a diagnostic code, so it says the patient in front of you is a smoker or a heavy smoker or a light smoker. And then you need a CPT code to go along with that. Excuse me, and the CPT code is the procedure code. And there's a number of different types of CPT codes. So you need both of those. You need the CPT code and the ICD-10 code to match up and be both covered by that insurance company or the Medicaid program or Medicare program. And then it needs to be done by a provider who's a recognized provider by that entity. So we can go to the next slide now. Going a little bit more into coding. So there's the biggest thing that we've talked about, and we've wanted, so we've talked with Medicare, Medicaid, CMS, and there's really not a way to kind of, for CMS to say, this is what is covered, period, and this is what has to be covered by all Medicaid managed care plans, by all Medicare plans. Like, very individualized. States have a lot of leeway in what they can do. So there's a number of coding issues. And again, if you go through the billing guide, there's more information there. So there's ICD-10 codes. Again, those are the diagnostic codes. ICD-10 is the version of the diagnostic codes. They're much more detailed than ICD-9 was. So just, it's important to get that detail in there. And then there's also the difference between the clinical codes versus the inpatient codes. So sometimes they're recognized differently. And again, even if you're in a state and working with Medicare patients, for example, Medicaid patients, for example, one Medicaid MCO could be completely different from another. So it's really important to know them. For procedure codes, you're almost always going to be looking at level 1 codes as coverage codes. Another option for diagnostic codes are some Z codes. And so Z codes are, a lot of times, the most common use of them might be a pediatrician, for example. So the Z code is actually going to be the patient who's a child, who's a non-smoker, but the parent is a smoker. And so the Z code would actually be a code for secondhand exposure to secondhand smoke. And so they would counsel the parent, but that's going to have a health impact on that child who's the patient in front. And those are much less likely to be covered, but could potentially be covered if that, depending on where you're at. So we can go to the next slide. So I kind of got into this a little bit before, but kind of who makes the decisions and what's covered. Again, there are dozens of ICD-10 codes. And then there are, probably 3 or 4 counseling codes. There's the different sets of counseling codes for tobacco cessation counseling. There's a group counseling code. And then there's 2 different sets of counseling, individual counseling codes for both short counseling. So I think it's less than 5 minutes, and the other one's 5 to 10 minutes, or 7 to 15. Please, I apologize. I don't quote me, but feel free to look at the billing guide, and I can send that around, Becky, if you don't have it. I can do that. The federal government really does have a limited role. It's really at the state level or at the individual plan level. Go to the next slide. And then this is the billing guide, which I'm happy to share around. It's right here. It's nice if you print it off. But again, it's really kind of to educate providers on what they need to do and what they need to look up, and what, as a public health entity, as a person working with providers, kind of how you can help educate people, because there isn't a one-size-fits-all, and there's not a really great one-size answer for everything. So this goes through on kind of, what billing, what tobacco cessation is. So it gives you a brief kind of, this is what it is and this is what should be covered, kind of for different types of things. And then it goes into kind of what the different types of codes are. What are the ICD-10 codes? What are the CPT codes that you could use? And then kind of where to look up, how you figure out what is appropriate for an individual provider and an individual patient. So that is kind of what the billing guide does. Again, we really wish that we could have said, this is how you bill for stuff, and that was what our intention was. And the more research we did, the more we realized that that wasn't possible, and it's really kind of a very specific thing. And it's a provider and an individual plan and an individual Medicaid, state-by-state basis. So if we go to the next slide, because now I've just depressed everybody. So some state actions. So if you go to we go to the next slide, I think kind of the first thing to do is to look at coverage and review the coverage, and so see what is covered, to see who can be reimbursed. And so this is a couple of different things. So one, look at what the licensing requirements are in each state. Again, Medicaid is, I think, a really good place to start with this. It's a state-based entity. The state makes the decision. But there are a number of different states that have different things. There are some states where the primary care providers are the only providers that are allowed to bill for cessation treatment. And that is the case in, I know, at least 2 or 3 states from the top of my head that only allow primary care providers. And so if you're working with cardiologists, and cardiologists can't bill for cessation counseling, and that's clearly a problem, but it's just the way it is. And you would have to work with the state to change that. There are other states that have much more flexibility in who can bill for this service. So it really kind of just depends. And Pennsylvania is a really good example. They've got a great website that lists probably a dozen different provider types that are able to bill for cessation coverage, and it's not just primary care providers, it's any MD and OD that can do it, as well as a number of different other types of providers that aren't necessarily medical doctors. And so I think kind of looking at who can be reimbursed, looking at kind of what codes are allowed to be reimbursed, and then to see kind of if it aligns with where your state is otherwise in their tobacco cessation. If we go back to that previous slide. Anyways, not important, perfect. And then looking at, state plan amendments, if there's a way, if your state is working on a state plan amendment for something, can you add tobacco cessation into it? We know it's a big process and not a lot of states do it, but are there ways to do that? And kind of ways to jump on the bandwagon? Or can stuff be done through administrative changes? Can it just be good on what Medicaid does? And then also look at the managed care organizations, because sometimes they'll have more flexibility than the state Medicaid program as a whole. And then the last slide is just my contact information, and I'm happy to take any questions if this would be helpful now, Becky, or I'm happy to wait till the end as well.
No, this is great. Thank you so much, Anne. And it's so frustrating to see what a wide variation there is, and so easy to understand why this is such a problem. So I really appreciate you making that as succinct as possible. There's a lot of information that just went in there, so thank you. Does anybody have any questions?
This is Angela from California. Where do we find who is eligible to bill for our particular state?
So in California, I would start with the state Medicaid office. And so there's a couple of different ways to start. So you've got a lot of managed care plans. So either start kind of at the level of Medi-Cal and see, like, does Medi-Cal have a policy? Provider manuals might have something like that. Additionally, state contracts with different providers would have it. Or if you specifically work with like one managed care organization, depending kind of on how you're set up and kind of who you work with, you might just work directly with that managed care organization and not work broadly over the course of the whole program, because there could be some variation there.
So we have to go to each individual insurance company and ask? Most of our clients are Medi-Medi. Okay,
so I actually don't know what Medi-Medi is, because I think that's a California specific.
Medi-Cal, Medicare.
Okay. So you've got a lot of dual eligibles. So Medicare is going to be Medicaid is going to be your payer of last resort. So Medicare. So look at CMS's website. Depending on, I don't really know how they bill. So I'm assuming they'll bill Medicare first, and then they'll bill Medicaid second.
Right.
Medicaid's the payer of last resort. Yes.
Okay.
I'm sorry. This confusing question, but so I would start so if anybody is a eligible provider under Medicare at the federal level, they should be able to bill. I was just on a call previously, and I do know that there's some question about TTSs being able to bill under Medicare, which is just generally automatic, and so there's a group of people that are trying to organize around that. Most providers are eligible to bill under Medicare, so they should be able to be reimbursed there. Patients under Medicare should get 4 sessions twice a year of counseling.
Okay. Okay, great. Thank you.
And would the guide be a good place for her to look as well?
Yeah, so the guide is going to help you kind of go in a little bit deeper than that. Like, the guide's going to help you figure out what you need to try to find.
Okay, great.
If that's helpful.
And I'll send the guide back around after this. It is in the Partner Hub as well if anybody needs it right this second, but I'll send it back around. And then we have, I think, time for one more question. Do providers often have to register cessation counselors and do a training in order to bill for counseling? I've seen this before.
So it's really going to depend. So typically, again, it's going to depend on what type of provider they are. So if you're an MD, you're probably not going to need to do that. But I think it's really unfortunately, it's very dependent on like specific plans and specific types of plans. There's not just kind of a universal, you have to do this or you don't have to do that. Typically, though, you're more likely to be reimbursed if you've got a license, a medical license of some sort. If you don't have that medical license, you're less likely to be reimbursed just in general.